Okay. Get started. Turn the light off. I know you guys don't like the lights off, but I can't see with too much brightness. So it's too much glare. I can't see. Okay, so we're going to finish up musculoskeletal rheumatology today. We went through disorders of the joint the other day. We went through osteoarthritis, rheumatoid arthritis, and Charcot joint. So make sure you understand the differences between those three. Today, we're going to go through a little bit more about the bone itself and talk about disorders of the bone as we go through different topics today, bone fractures, and other disorders of the bone itself. So just review again, function of the skeletal system, support, protection, and locomotion so we can move. We know it gives us our stem cells, so we know red blood cells form here, all those other cells. There we go. And storage of calcium and phosphate. We talked a lot about calcium metabolism at the end of physio when it comes to like calcium metabolism in bone, when it comes to vitamin D, PTH, all about the role of calcium. We know the calcium is stored in the bone. We pull from it when we need it. Epiphyseal plate is that growth plate. That's very important to know where that is. And when we talk about fractures, if it broke or not. And periosteum is the outer covering of the bone. With regards to long bone anatomy, so your femur, humerus, all those long bones, the diaphysis is the shaft itself. This contains the medullary cavity, which is all the stem cells. That's where they all grow from. So the diaphysis is the actual shaft part. The metaphyses is the flared bone region at the end of the bone, and this has spongy bone in it. So here's your metaphysis up here towards the top. Has cancellous bone. That's going to become important when we talk about different types of diseases because it changes the type of bone. And the epiphysis also has red marrow, but it's replaced by fat marrow later on as that bone matures. So the epiphysis is at the very top. There are two types of tissues in all bones. We either have cortical or compact bone. This is in the shafts of your long bones. So the main part of your bone is going to be cortical or compact. This is your mechanical protectional forces. Has these overlapping cylindrical units termed Haversian systems or osteums. The reason why I bring this up is when we talk about osteonecrosis. Osteonecrosis is going to use these little channels to get that bacteria and all that pus inside the bone and cause issues. We also have trabecular or cancellous bone. This is spongy bone. This is usually at the ends of the bone, as well as flat bones and any of your vertebral bodies. It will have this as well. Has a meshwork of trabeculae. A lot of metabolic activity happens in this trabecular bone and serves to reduce skeletal weight. Okay, our the bones do weigh a lot, and if they were totally solid, they will be very heavy. But we have some cancellous bone, spongy bone to allow some air pockets so that it gets lighter. That's why we can't fly, but birds can because their bones are lighter than ours and they don't have that weight. Bone is dynamic and it's formed by three different types of cells. We have osteoblasts that build bone. So they're going to be making more bone. So the B for building. We have osteocytes, which is mature bone. And we have osteoclast with the C, and their job is to degrade the bone. So they're very active when we need calcium in our bloodstream. So osteoclasts come out, break down the bone, get all that calcium back into the bloodstream, and then they'll stop later on. Those are the jobs of those. So our bone remodeling cycle, PTH is going to be the big one as far as the hormone responsible for the bone remodeling. In a acute phase of PTH release, we know it's going to break down the bone. So we have to have active osteoclasts in this area to degrade the bone, and we get, they remove all that bone. But we can't have PTH going on forever because eventually you're going to keep degrading all your bone, degrading it. So what happens is over time, if you have a chronic release of PTH, it turns into an anabolic cause and it starts to rebuild that bone back, getting your osteoblasts active to remineralize that bone that was degraded. And then eventually you get your osteocytes, which is the mature bone, and now the bone is back to normal. So in the acute phase of PTH, it's going to come out to bring the calcium levels back up. But if you did have a disease where PTH was chronically being secreted all the time, over time, months later, eventually the PTH will be an anabolic source and build the bone back up. It's like a protective mechanism so we don't just dissolve our bone. Or you can just drink Diet Coke. That'll do it too. You ever put a bone in Diet Coke and let it sit there for a while? No. Do it. I don't know if you want to drink Diet Coke again, but it'll strip it. It'll strip the bone. It'll dissolve it over time. Yeah. Actually, you know this about Coke? I read this thing too. Like for some reason, the cola flavoring for some reason doesn't saturate your taste buds on your tongue. So every sip of Coke tastes amazing. But orange soda, after a while, you're tired of it, you can't drink it anymore because your taste buds are all saturated. That you get a different flavor profile. But for some reason, Coke is a fresh taste every time and tastes good. I don't know why. I don't know. Weird stuff. When you know how the body works, then you know everything. So whether they're lying or not online. Okay, so moving on to bone again. So we know our bone are constantly being reabsorbed and then new bone laid down, and so it's constantly being remodeled. So it's a constant rate, except during childhood development when obviously we're building bone like crazy so that kids can grow and get to a normal stature. Continuous turnover allows bone to respond to increased stress and prevent fractures. So we talked about this a little bit on Tuesday. The compression of the bone, the compressive forces, strengthen the bone itself. And I don't think I had it here, but remember what the law was that does it? It's Wolff's law. Okay, so the constant movement, weight-bearing activities. So when you get to a patient education later on, you got to figure out, can your patient do a weight-bearing activity, walking, running, jogging, or do they need to do a non-weight-bearing activity because they have bad knees or hips? Swimming, cycling, those are non-weight-bearing activities that they still can do and get the benefits from. Regulating hormones, obviously PTH is the big one with our extracellular calcium. Osteocytes release calcium stored in that lacunar spaces. Osteocytes is the bone cell, so they have it and they release it all. And again, it's a rapid response to hypocalcemia. If the PTH stimulus continues, osteoclasts are coming out to resorb that bone breakdown, and it dumps all that stuff into the bloodstream. So we can get calcium back into the blood. That's what matters. Remember, it's the blood calcium that matters, not the calcium in our bones. It does matter, but from a clinical standpoint, and what the body cares about calcium in the blood. So what does PTH do in the kidneys? Increase phosphate diuresis by decreasing the resorption of phosphate. Why is that important that PTH does this at the kidneys? When PTH has its effect on the bone, is just calcium released? Calcium and phosphate are both released into the bloodstream. We don't want that extra phosphate. We want the calcium, but as a consequence, the phosphate comes along for the ride. So we have to do something with it. So we kick it out of the kidneys and we get rid of it. So by PTH also dealing with increased secretion or excretion of phosphate allows the PTH to do its job, only raising calcium in the blood, the phosphate we just pee out. Increased tubular resorption of calcium. So where is the calcium going to go? Into the blood. Remember, kidneys resorb back into the bloodstream. Remember those definitions for renal: secretion, filtration, excretion, resorption. So we reabsorb there. And it also stimulates the kidney to make more of the active vitamin D. So we need to activate vitamin D, which in turn is going to help our calcium absorption where? Vitamin D helps us to absorb. I'm saying absorb for a purpose. Intestines. That's where we absorb things the first time. We reabsorb in the kidneys. So get those words correct too, the definition words. Absorption is the first time we're getting it. Vitamin D helps with the absorption of calcium from the intestines. So PTH, increased permeability of gut cells to calcium. The gut is indirect because it's going to activate vitamin D, which will then do that's why PTH is an indirect calcium absorption from the intestines, because by way of the kidney, activates vitamin D, which will then go to the intestines to activate that. So here's a little slide kind of going through everything, what PTH does. Calcitriol is the different versions of vitamin D. So again, ways to raise calcium if we have to. Vitamin D from food or from UV rays, stored in our liver and fat, stored when vitamin D levels are high. So once you saturate your body with vitamin D, we'll store the rest of it. Some of the other things we don't store, we just pee out. So if you start taking supplements, you have very expensive pee because you'll pee a lot of that out. When vitamin D levels are low, we release it from the stored places. Vitamin D is metabolized to calcidiol in the liver, and then it's calcitriol in the kidney. The calcitriol is the active form of the vitamin D that we need. And obviously regulated by PTH and our vitamin D levels in the blood. Primary target is the intestine to increase calcium absorption. In the bone, augments PTH-stimulated resorption of bone, may have some role in mineralization. And in the kidney, vitamin D will have a feedback effect on itself. So when calcitriol levels are high, we don't need more active vitamin D, we just shut it down. Once we hit our set point for vitamin D levels, negative feedback on the kidney, and we stop activating vitamin D because we don't need it anymore. We've saturated everything. Calcitonin is secreted by thyroid glands, mainly the C cells in the thyroid. Main effect is to inhibit osteoclast resorption of the bone. It's very, very weak in humans. We don't really look at calcitonin very much. Where we do look at calcitonin is in cancer states or disease states. So used in disease states characterized by increased bone resorption. And the first disease that we're actually going to look at today is Paget's disease, and we'll do osteoporosis later on as well. But so we only look at calcitonin when we suspect a underlying disease, something else is going on. But calcitonin is going to stimulate osteoblast. Obviously, it's going to build bone, and class to inhibit those. Yes?
This may be a dumb question, but I don't, what does it mean, inhibit osteoclastic reabsorption of bone?
So what do the osteoclasts do?
Break down bone.
So if I'm going to inhibit that,
So to not break down bone?
okay. So that's all it's going to do. So all calcitonin is going to do is stop the osteoclast from breaking down the bone and stimulate the osteoblast to start building more bone. So again, we want to, this is in cases of high calcium, theoretically in high calcium environments, calcitonin should come out and say, hey, we've got enough calcium, start building back our bone again. That's kind of the role of calcitonin. Again, we maintain serum calcium levels at physiological levels, even at the expense of the skeleton. The serum has priority over the bone every time. Phosphate metabolism, we know this comes out as well. We talked about phosphate when it comes to titration of acids in the kidneys. So I'm not going to go into detail about that, but we know that phosphate we get rid of in the urine. Other hormones involved with metabolism of bone, we have insulin here, because we know that insulin causes growth, protein synthesis, growth of things. If you're pregnant and you have gestational diabetes, your baby gets bigger because the insulin goes up. So again, all those things. Thyroid hormone, needed for growth and development. Growth hormone also has an effect on our skeletal system. Obviously, we need it for growth and development of our skeletal system. Sex steroids, estrogen, more than testosterone for bone formation. Inadequate amounts result in chronic loss of bone mass. So that's why estrogen is important. And glucocorticoids in excess. What is a glucocorticoid? Cortisol. So we have excess cortisol, impaired skeletal growth, and decreased bone formation and bone mass. So glucocorticoid excess. So we look at people who have rheumatoid arthritis, they're going to be on prednisone for life. So if you know someone's going to be on a steroid for life, you would want to do what every year? DEXA scan. Check their bone mineral density every year because they're on glucocorticoid excess. We shouldn't be taking it exogenously, but some people have diseases where they need it. But okay, so we know that. So let's account for every possible side effect from that. Let's do a yearly bone scan to see how dense your bones are. Estrogens in bones, again, we talk about menopause, estrogen levels drop, and skeleton rapidly loses bone mass. Major deficiency of estrogen, age-related bone loss. The reason it helps is acts upon osteoblasts and osteoclasts. So estrogens themselves will help to stimulate osteoblast activity and decrease osteoclast activity, therefore keeping your bones strong. And that's what estrogen does. Okay, now let's go, we finished our anatomy and phys, now let's get into some diseases. So bone diseases, Paget's disease, and gout are the two that we're going to cover. Paget's disease of the bone is also known as osteitis deformans. Whenever we have a disease that has two words, two ways to say it, make sure you know both of them. Either of them are fair on an exam. So make sure you know that osteitis deformans is Paget's disease. Same thing. Because there's a bunch of those for ortho. Because if you discover the disease, you get your name after it, but whatever. So what is Paget's disease? Disordered bone remodeling. Okay, we get a lot of bone resorption. We start degrading that bone in a kind of unchecked environment, and it just goes rapid. So we get these lytic lesions followed by disorganized and excessive bone formation. So we get a lot of excess bone withdrawal, and then we put it back in, but it's no organization because it's going too fast. So it's not laid nice and neat. Everything's kind of thrown in there, and we get this disordered bone organization. Lesions may be solitary to like one bone, or they can occur at multiple sites. Different bones could be affected. Usually bones of the axial skeleton, the head and the trunk. It can get so bad for people with this type of disorder, they can't support their head anymore. The C1 collapses because of the deformed bone. They can't hold their head up. Second most common bone disorder in the United States. What's number one? Osteoporosis. Okay, affects men and women over 50 equally. Okay, increased incidence in people of English descent and etiology unknown. So Paget's disease is a triphasic disease. There's different phases. There's a hot phase, which is osteoclast activity. So what are we doing to the bone? Breaking it down like crazy. Cortex thickens, causing bones to become larger than normal. Oh, sorry, wrong one. Osteoclast activity, reducing bone marrow fibrosis and dilation of those little sinusoids. In the mixed stage, now we get both osteoclast and blast activity. They're both kind of working, but it's in a mixed stage. Cortex will thicken, and I'll show some x-rays. You'll see the cortex of the bone is very, very, so what color should it be if it's thick, dense bone? Bright white, right? The brighter the white, the more dense that bone is. So what's happening here, it's trying to rebuild the bone back to normal. So that's that mixed stage. Finally, at the end, we have a cold stage or a burnt out stage. Very little cell activity. And in this case, you'll see some really, really funky x-rays going on with these patients. The disease may proceed through all phases randomly and have components of all stages at once. So it's not like it only goes from hot to mixed to cold. They can have all three going on. Maybe just one is enhanced at this point in time. But those are the three different phases that are going on. So here is looking at the trabeculae. You see how nice and clean the top one is? And then look at the bottom one. Obviously that bone's going to be very weak now. Not nice, clean, laid down. This is all histology. So osteoclasts of Paget disease are huge, main number greater than 100 nuclei. The trabeculae are distorted and irregular, which is right there. Bone collagen is arranged in a woven pattern rather than a lamellar pattern, which is lamellar meaning straight lines. Woven is moving around. Woven is not strong when it comes to bones. Okay? In the burnt out phase, you get what's called a mosaic pattern. So if you look at the top, nice and clean, everything looks really good. On the bottom, resembles like a mosaic. You know, when you make those little mosaics, all the broken tile, you put them all together. That's kind of what it looks like. And again, you can see the picture here. Nice on clean on top, and on the bottom is the disorder of the Paget's disease. So what kind of symptoms do they get? Pain in the affected bone. Obviously the bone's getting more weaker and brittler. Going to cause some pain there. Again, usually the axial skeleton. Skull is frequently involved. Skull can become also very heavy and will collapse over C1. Hearing loss follows involvement of the ossicles, so they may get some hearing loss later on. Fracture and arthritis. These bones will snap transversely. They get very weak, they'll just shatter on their own. High output cardiac failure is rare, but it can happen. The blood gets shunted to the bones due to the increased demand. So basically, blood should be going to the muscle in the body, but instead it's getting sucked into the bones, which don't need all that blood. But because of all this metabolic activity going on, and we know that the bones have a very good blood supply, if you're increasing the demand, the blood supply is going to go along with it, but we don't want the blood being pooled in our bones. So we get what's called high output cardiac failure, because instead of the cardiac output going to our muscles and the cells, some of it gets sucked into the bones, reducing our cardiac output. Diagnosis is often incidental. They'll come in with pain. You get an x-ray done. You're like, oh my God, it looks like this. You probably have Paget's disease. So here's what an x-ray looks like of Paget's. Look how bent the bone is. That's your tib fib right there, by the way. Okay, yeah.
So this is in older people.
Yeah,
right?
older
This
people.
isn't the one that's like the one with it.
Mm-mm. No, and you see the bone there, and you can see obviously how curved that leg is because of the Paget's disease. This abnormal bone remodeling causes the bone to change shape, essentially. So that's Paget's disease of the bone. Any questions about Paget's disease? You'll get to that in CMS. Yes?
Are there any genetic like predispositions to it?
I don't think so.
Okay, so it's just like
Yeah, I would have put it in there if it was. So I don't think so.
Yeah.
Okay, so moving on to gout. Metabolic disorder. Okay, gout is a metabolic disorder, not a physical thing. You didn't do anything to it. Elevated serum uric acid concentration, so hyperuricemia. Incidence has increased with the rise in obesity and hypertension. It's common, 8.3 million in the United States, so about 4% of the population will have an episode of gout at some point. Typical range, 40 to 60, 69, 70. So older population. Monosodium urate crystals, make sure you know what that is. Remember that for gout, monosodium urate crystals. Deposit in and around the joints and tendons, and they supersaturate. So remember we talked about if you like your coffee like I do and you have too much sugar in it, eventually you can't stir all that sugar in because it saturates out. You've had too much sugar in it. That's what happens with hyperuricemia. You have too much uric acid in your blood. It saturates your blood and it crystallizes out into these little crystals. These crystals are little needles. And imagine these little needles inside your big toe. And every time you move your big toe, those needles just dig into those little ligaments, the tendons, and the muscle. That's what gout feels like, basically. It's just little needles in the joint, and every time you move, it pushes those needles in further. Plasmic uric acid greater than 7 for this really to happen. It can be recurrent, it can be acute or chronic, and obviously it's going to be arthritic of peripheral joints. You can get some joint deformity if they have recurrent gout in the same joint. Remember, repeated injury causes problems. And gout, if you constantly get it, you get repeated injury. There's some medicine you give for people who have recurrent gout. They take it chronically every day to help reduce the uric acid levels. If it's just a one-time thing, they treat to flare up, and then you kind of go from there. There's a little bit of a genetic component here. Primary is without any other disease. That's about 1/3 of the case. But a secondary cause of gout, these have an underlying cause that would result in hyperuricemia. Yes?
Is there actually a reason why it mainly affects the great toe?
It can affect every toe. I think we get into that later, but I think it's just the way that the blood supply works. It kind of just forms and gravity gets all the way down there. Secondary reasons, increased DNA turnover, so leukemia, lymphoma, and any type of chemotherapy. With high turnovers, they are at risk for gout. So uric acid results from purine catabolism, so a high purine diet or high synthesis of purines will do that as well. I think I have a picture of purine foods. Yeah, I do. So etiology, what causes gout? What are the different causes? One of them, overproduction of purines. Are you making too much uric acid yourself? So obviously that's going to make it go high. This is a purine salvage pathway defect, about 10% of the cases. Basically, you're not reusing your purine. Remember, we talked about bilirubin, and we reuse that bilirubin. Well, purine we're supposed to reuse as well. Sometimes you have a defect, you don't reuse it, so you're having the stuff that you're supposed to reuse, and you're making more of it, so the levels rise. The next one, decreased uric acid excretion. So the kidneys get rid of things. If the kidneys slow down and they're not getting rid of things as fast, it will build up in our bloodstream as well. And if it gets to a certain point where it saturates, it'll crystallize out. So 90% of idiopathic cases, again, impaired renal function. So if you know your patient has chronic renal disease, and their GFR is low, be careful with certain foods and medicines because they can't clear out the uric acid fast enough. The next cause, diuretic administration. If we have a solution, but we have a solvent and the solute, and we remove the solvent, what happens to solute concentration? It goes up. So what are we doing with the diuretic? We're getting rid of the solvent. So the solute concentration goes up. So this is another way we can get high uric acid. So I could put example 1, example 2, example 3, and example 4, just so they're not all in sequence. They're just different examples of ways to have uric acid. The next one, increased catabolism, breakdown of nucleic acids, psoriasis, myeloproliferative diseases are this cause. So these are just 4 ways to increase uric acid in the blood. So these are foods that were high in purines, a lot of your fish, anchovies, herring, organ meats, so sardines, yeast is here as well. Lobster has a lot of purine. I can't remember, there's like a, if anyone else remembers it, like back in the medieval times, like, I can't remember if it was the kings that ate the lobster or the peasants that ate the lobster. The kings ate the lobster, right? That's why the gout was like a rich man's disease, because they can only afford the lobsters. But they had all the uric acid, and they developed gout, so they got gout.
But you have to eat this like all the time.
Yeah, you have to eat a lot. Yeah, yeah. You can't just be like once. It'd be like chronically eating it a lot. Yeah. Okay, so we talked about how the uric acid will crystallize out, and when it does that, it forms these monosodium urate crystals, MSU. And these things get deposited in different areas of the body. Avascular tissues, like cartilage, they'll pop in there. Relatively avascular, like tendons and ligaments, they do have some blood supply, but relatively avascular. Cooler peripheral joints. So Hannah, here's your toes. Why? Because they're very cool down there. And other air tissues. Your ears are pretty cool. You can get gout in your ear. I think I have a picture of that. But you can get a nodule, a cyst formation in the ear as well. In severe, long-standing diseases, they can get into the bigger joints in the organs as well. So this is the big thing to remember. The crystal deposition is influenced by temperature and blood flow. And that's why it's very, very common in the distal joints. The pain is very exquisite. There are certain diagnoses where they use the word exquisite pain, which means it's like extreme, localized to one area pain. One of them is gout. If you know someone with gout or have ever had it, just by like moving the sheet across the toe will cause exquisite pain from that inflamed hot joint. Another one is a disease of the trigeminal nerve called tic douloureux, where you have extreme facial pain, like even like doing this will cause like exquisite type pain in your face. So there's certain diseases that use that type of word. So this is what it looks like. Obviously, looking at left and right is just different filters, but basically those are what the crystals look like, all little needles that get into the joints, and obviously whenever you move, they're going to cause a lot of pain. So acute inflammatory reaction, they're going to get into that tissue, cause pain, inflammation. Obviously now we have to have a reaction to that. So the joint becomes red, warm, very tender, activates the kinin system, so we get local vasodilation, pain, swelling in the complement pathway. All this inflammatory stuff we learned in lecture 1, we went through all inflammation and stuff. Then we get phagocytosis of the crystals by macrophages. So we have to get rid of the crystal, so macrophages are the ones that eat all the debris, and their job is to get rid of it. So we get neutrophil adhesion, and migration is facilitated and amplified. So neutrophils get to the area to try and break it down and digest it and get those crystals out. Inflammatory response will downregulate spontaneously and completely over several days without therapy. So gout is what's called self-limiting. Means it will take care of itself, it goes away on its own. Just like the common cold, it's self-limiting, it goes away, you just gotta ride it out. Usually little destruction to the tissue on a first flare-up, but when it's the repeated ones, you start getting problems. So here's what gout looks like. They start without warning. First symptom is usually acute monoarticular pain. Why is it important that we talked about monoarticular? Yep, because remember, the osteoarthritis, rheumatoid arthritis are usually bilateral symmetrical joint pain. Gout is monoarticular, one joint is affected. So whenever you have one joint, there's got to be a reason for that one joint to be affected by this. It could be gout, it could be other things, but we'll go from there. If the MTP of the big toe is the one that's involved, it's called podagra. So if you ever hear podagra, whatever you call it, it's gout of the big toe. Just another way of calling it podagra, gout of the big toe. May be precipitated by a large meal, drinking alcohol. So if you had a big feast of lobster and you had a problem with your uric acid metabolism, the next day you may have a flare of gout. Trauma, surgery will be there as well. Manifestations, pain, progressively more severe, excruciating. Signs resemble an acute infection. Okay, swelling, warmth, redness. Here's your exquisite tenderness. I mentioned that word, exquisite. It shows up in certain diagnoses. Overlying skin is tense, warm, and shiny because the skin is being pulled. Okay. Look at this area compared to normal tissue on that side. So red, inflamed, whatnot. Instep, ankle, knee, elbow are also common sites. Fever they may get just from all those acute inflammatory cytokines being released. Again, we have parts of our brain that sense these things, and if enough of them are released, the hypothalamus will sense it and raise a fever, yes.
What is instep?
This just kind of shows the different stages of gout. You don't need to know. Just know that obviously if 1 to 4, 4 is mainly the more severe forms of gout. 1 is asymptomatic hyperuricemia, where you have high uric acid, but you don't have any signs or symptoms of gout itself. And then the acute flare-up occurs in stage 2. You don't need to know the rest of the scales. So podagra, again, and episodic oligoarticular, so it's both of them. We'll waken them up at night. They'll wake up because the sheet will rub against their toe, causes pain, they wake up. Gouty arthritis will have birefringent urate crystals with PMNs. So that is gouty arthritis. Tophi. Okay, these are firm, irregular subcutaneous deposits of urate crystals. They look like they're nodules. But basically all it is just uric crystals, uric acid deposited into these little areas. Tendinous tissues, and again, the ear. You can also get erosive arthritis if you have repeated attacks to the same joint. It's got to be the same joint involved. You may have some renal issues as well. These are those nodules, but these are tophi. These are from uric acid. They're not rheumatoid nodules. How would you know the difference between rheumatoid nodules and gout nodules?
Symmetrical.
Could be symmetrical. Also do lab work. What would you see if it was rheumatoid arthritis? What would show up in the labs? Those ANA, those seropositive markers. You won't have those if it was gout, but what would be elevated if it was gout? Your uric acid. So if you saw, normally uric acid is not something that is a routine order on your labs. You could say CMP, BMP, all you want, it's not going to be ordered. You have to actually specifically order the uric acid. And what is the reason that you're ordering it? I suspect they may have gout, because they have these little tophi nodules. I want to rule it out. So you get your labs, and uric acid comes back normal. We know that's not gout. And you go on from there. And this is what, again, polarized uric acid crystal. Again, there's different ways to look at these things under a microscope. Understand what uric acid, the birefringent, monosodium urate crystals. Okay, let's take a break. Come back at 10:50. Okay, let's finish up. I'll try and finish up this lecture today. If not, I will finish the rest up on Monday or Tuesday whenever we have class again, and we'll start renal next week. Ugh. I know, right? So renals next week. So fractures, a break in the bone caused by trauma or physical forces, most common in bone lesion. When you guys get to peds, you'll start learning about violence and abuse, and they'll talk about different fractures and where they occur, meaning are you suspicious of abuse with certain fractures or not? Adjacent soft tissues are also injured. You may result in some muscle necrosis because of depending on how severe the break was. Did the bone fragments or did the actually bone break in half? And it's a sharp piece of material. What's it going to damage around the area? So muscles, you may get a hemorrhage. We know bones have a lot of blood supply. If you break your femur, you're going to bleed out like crazy. You can have tearing of the tendons and ligaments and nerve damage. So keep this in mind when you guys are doing your physical diagnosis. When we say the review of systems, so if someone's coming in with knee pain, what are all the systems inside the knee that you have to be worried about? And that's what we're dealing with here. The muscle, any bleeding, is the joint effusion? Do you have all the swelling going on? How is the laxity of the joint? How are those ligaments and tendons? Are they still working okay? That's why you do your range of motion. Nerve damage. So do they tear a nerve? How is their sensation past the knee? Can they still have sensation in the toes? Do we have any nerve damage in the knee? Years ago, the quarterback for UCF, who tore up his knee, Milton, right? Like, he almost lost his leg. The damage was a lot worse than people thought. Like, he tore the arteries in his knee as well from the fracture. So, like, it was a lot of repair done. But, like, again, these are the things to start thinking about when you're dealing with the head. You guys did your OSCE for HENT. Anything in the head you have to ask about. If they have an ear problem, ask about nose, eyes, mouth, because they're all connected with those eustachian tubes. So you know they're all going to be communicating. So these things, so anytime you have a fracture, check for nerve integrity, vascular integrity, the muscle, and the joint integrity, because those are all things that can be damaged when you fracture the bone. Types of fractures, you got to know this one. Transverse fracture, just right across. Spiral, from a twisting motion. What kind of questions are very important to ask when anyone comes in with a fracture? How did it happen? Always know the mechanism of injury with any type of fracture. What happened to you? Oblique fracture, comminuted, this means you have many different parts. So when this broke, it broke into three different segments. That's a comminuted fracture. Segmental, you broke it in segments. So these are descriptions of fractures. When you guys start ortho, they're going to talk about what fracture or what mechanism of injury will result in a transverse fracture, what resulted in an oblique fracture, those type of things. But for now, just know what they're called. We also have compression fractures of the spine, the vertebra. You see this a lot with osteoporosis. Elderly women, they start shrinking because the spine is getting smaller, they collapse. They kind of have those things. The vertebral discs can also get thinner, so they get smaller that way. So I had mentioned one of the things we have to know is, did we break through the epiphysis or not? Salter-Harris fractures, this is not going to be on your test for me. You will have this in ortho, I 100% guarantee it. You might have it in med imaging, you might have it in room, but I know for sure you're getting it in ortho, so I'm not going to go into much detail, but just so you know, if you ever hear anything about a Salter-Harris fracture, you have to worry about the epiphysis, the growth plate. All we're saying here is that here's your normal, and then they grade them in severity. And if you look, you can see how in this case, in B, the growth plate is still intact. C, the growth plate is still intact. Okay? But look at D. Now we have a break in the growth plate. And E, you have a break in the growth plate. So those are the more severe ones. In patients with this, these are usually kids. When they break through the growth plate, you have to be very careful now. Is that bone going to grow appropriately? If this was a femur on the left, what are you worried about? Necrosis, but what about just in general, just this kid growing up? Uneven leg lengths, because now they changed. One's going to grow faster than the other potentially. So watch out for those growth plates. You're not going to be required to know, is this a Salter-Harris 1, 2, 3, or 4? Just understand that Salter-Harris deals with epiphyseal plate. You have a question?
Yeah, what would we do in that case?
I'm not sure, to be honest. Ortho knows all those questions. Like I said, I know a lot about a little, but the ortho treatment stuff I have no idea about. That's why you have the CMS classes. Other types of fractures. You can have what's called an avulsion fracture. And in this case right here, the lateral collateral ligament just pulled, what is that? What the landmark there? What is that? Well, figure it out. I don't know.
You don't know?
Is it tibial epicondyle or something? I don't remember. That's why you guys, I'm not being tested on anatomy, you guys are. No, but anyway, the point is this. That ligament pulls that point right off from the force of the injury or whatever it was. It causes an avulsion fracture. It pulls it right off. That's hanging there. That needs surgery to tack it back on for that. But that's an avulsion fracture. The other one is called a green stick fracture. This is an incomplete fracture. This is mainly seen in children. So I said about abuse. Why is this seen in children? Why is it called a green stick? Bones are very nimble. They can bend as they're kids and they grow up. If you have a green stick like off of a tree and you're trying to bend it, eventually it'll turn into a curve and then it breaks on one side of it, will break on one end. If you have a dried out piece of wood that's old, it cracks right in half as soon as you break it. But a green stick will split like that. So this is seen in, sometimes you'll see it in abuse. Pulled out of proportion and they break. So green stick mainly in children because the bones are still soft, pliable, and they bend that way. Tibial stress fractures. So again, high stress areas. Anyone runners here that do a lot of long distance running have stress fractures in your feet? So it happens with the constant pounding of the pavement, causes micro stress fractures in the feet. Pathologic. These are usually due to a tumor. You can see right there, the tumor's in the bone, and you can see the fracture right here. You guys see that? Now, so pathologic, usually due to tumors. Many, this is before most of you were born, there was a pitcher in the baseball, Major League Baseball, who had a history of cancer, beat the cancer, came back to pitch again in the major leagues, threw a pitch, and while he threw it, his humerus just shattered. Pathologic fracture. He didn't see anything, but you can see his arm just go like limp. But yeah, he like fractured, pathologic fracture due to the underlying tumor, made the bone weak, and it just shattered the humerus. So that is all different types of fractures. So let's talk about what happens when you finally do break a bone. What is the healing process? So first thing is a hemorrhage. So we broke a bone. Bones have a lot of blood supply. They're going to bleed in the area. We have to stop the bleeding, so we have to form a clot. We know how clots form. Platelets get there first, stop the bleeding, and then go on from there. We don't do all that stuff. We get extensive bone necrosis due to ischemia to the bone. So that avulsion fracture, where that lateral collateral ligament pulled the tibial tuberosity, whatever it is, right? Tuberosity, or is it condyle? Anyway, the tibial bone off. That bone is flapping now. Does that bone have any blood supply? No. It's just hanging on by that ligament, which we know doesn't have any blood supply, and it just hangs around. You're going to cause necrosis of that avulsed bone unless you fix it. So that bone will undergo necrosis. That clot eventually must be resorbed for the fracture to heal. And we get what's called neovascularization due to early fibrosis, but basically we are making new blood vessels to connect the broken bone back to the main bone. So we're connecting blood supply so that we can get blood supply back to the broken one so it doesn't necrose. We get woven bone is formed after about 7 days, and that's a scar. And at the fracture site and within the bone marrow, this all happens. We get pluripotent cells give rise to osteoblasts. That's the bone building cells. We need to repair the bone. Therefore, we need osteoblasts to come to the area to start rebuilding that bone and remineralize those two bones back together. Cartilage is also formed, granulation tissue is also formed, and that's called a callus. You will see callus formation on an x-ray in healed bones. That's how they figured out, like scientists looking at bones from like 10,000 years ago, they knew they were a civilized society because the people's bones had calluses on them, which means that they were healed or they weren't just left to die. Like if you have like a, think of it back then, survival was very important. If you had a broken leg, you couldn't transport, they would just leave you because it was just more energy to carry you. But they actually did, so therefore the bones healed. We saw calluses on the bones, which means they were healing people. So here's starting your fracture repair. Again, callus formation. Usually where the fracture occurred, because of all this callus formation, the extra bone growth, that actual fracture repair is actually stronger than the bone around it. So in rare cases, like the bone around it can break next to it, but it's very, very rare that happens. But again, that's your callus formation, healing that bone, bringing it back together. Then we get the reparative phase. So after the first week, this will last about several months. And again, this is continually remodeling that bone, bringing those two pieces that broke back together to form a new union for the different cells. Obviously, fibroblast and osteoblast activity is going to be enhanced. We have to repair this damage, bring them back together. The repair proceeds from the periphery inwards, so it starts on the outside and works its way back in. So the osteum will form first, the outer layering of the bone, and then they'll work their way in. And then eventually organize and resorb the blood clot, and we get our neovascularization to bring blood supply, which you need for healing. Then the last phase is the remodeling phase. Several weeks post-fracture, the callus has sealed the bone ends, and now we have remodeling. Bone is reorganized along stress lines and mechanical forces, so we have cleavage lines. Just like in your skin, if you hit it hard enough, will break naturally according to cleavage lines, the way that your skin is lined up. If you want to prevent like a really, really nice scar formation, if you do your scalpel cut with the cleavage lines of the skin, when you put them together, you won't have any issues. If you go zigzag, then you're putting them together in weird spots and it doesn't line up. And the original cortex is restored of the bone. So now we've healed the fracture and back to normal use. So this is just a way of looking at it again. This is your hematoma formation in step 1. Okay, we have our break. Blood is just pouring into that area, so we get a hematoma around the area. Then we get our fibrocartilaginous callus formation. We get an external callus. Remember, it starts on the outside, so it seals off the area. We start getting new blood vessels forming to connect the top and the bottom parts of the bone to restart the blood supply, because we need blood supply for healing. And then finally, last phase, you got this bony callus formation. Still a little bit of a bump here. Continuous, more vessels are being made. Osteoblast activity enhanced to remineralize all that bone, connect it all back. And then finally, the last one is bone remodeling. Now we're almost back to a normal bone, and you couldn't tell you had a fracture there. Maybe a slight bump in the bone, but normally the calluses will start to shrink and resemble normal bone towards the end. but you'll still have a slight bump where that fracture was. So those are the different phases of healing the fracture. Any questions about healing fractures? Yes?
Usually if you're like healthy, would it like restore like totally normal function? Like you shouldn't have any.
So that's what we're getting to now, the complications, but that's why you put you in a cast to immobilize the bone so they don't move, because those capillaries that are forming, those neovascularization, they're very brittle. And if you start moving your wrists around, if you broke your wrist or those things, you can tear those vessels. You start the healing process all over again. So we're going to go through now complications that can happen with healing. First one is a non-union. For it to be a non-union, the fracture must be a minimum of 9 months post-occurrence. So if it's a year later, it's not a non-union, something else happened. So 9 months or less, it's not healed, has not shown any radiographic evidence of connecting. So that's why I said use the word union. They bring them back together, but we can have a non-union where they don't come together. So you can see in this picture here, maybe a little bit of blood vessel formation there, but these two bones are not connected and they are not fusing back together. This is a non-union. They never connected back together. Causes for this, soft tissue at the site. Before the healing process can begin, soft tissue got itself in between the two parts of the bone that fractured. And they won't form again because soft tissue got in the way. Excessive motion, that's why we put people in immobilization splints after they fracture something so that the process of healing can happen as well. Infection, poor blood supply, or other causes for these non-unions. A malunion is it did connect, but it didn't do it in the right way. And you can see here, that is not normal bone. Yes, it did fuse back together. The top and the bottom did connect, but they're not straight lines that they should be. This is a malunion. They didn't form properly. Compartment syndrome is another big one, complication with fractures. It's a condition resulting from increased pressure within a confined body space, usually the leg or the forearm. So if you got a crush injury on your forearm, remember, the first thing that's going to happen is what when you break an arm, break a bone? Hematoma formation, all that bleeding going on. Well, if your body isn't stopping the bleeding, it's still going to keep pouring into that area. It's going to start causing a lot of swelling to the area. Basically, it gets stuck in a compartment like your arm or your leg. We can't expand anymore, and you start seeing the skin swell like crazy. So anything in a compartment is now susceptible to damage. Nerves, muscle, blood supply, organs. If it's in the stomach, you can have compartment syndrome of the abdominal cavity. If they were like in a car accident and a crush injury, it can happen there as well. So what happens is we get separated by fascia. Fascia is what covers the muscles, and that's going to start swelling along with all this blood that's going into that area. So after an injury, blood or edema may accumulate in the compartment. The fascia cannot expand, and you get rising compartment pressure. This prevents adequate blood flow to the tissues, causing severe tissue damage. Severe loss of function or death can occur from these compartment syndromes, depending on where they are. Yes?
Is this when they do like fasciotomy?
Yep. I got some fun pictures of that in a little bit. Again, most common, legs, arms, and abdomen. So if I said a patient was in a car accident to a crush injury to the abdomen, in your mind, somewhere, start thinking, oh, potential complication, compartment syndrome. I need to worry for that if they have internal bleeding. Things start falling into place as you learn more diseases and stuff like that. So swelling, again, we went through the ROS in the knee. We know that nerves are there, muscles are there, blood supply is there. So if we have compartment syndrome in that compartment, all those areas, all those systems are also going to be affected as well. Blood vessels and nerves get compressed, you get some pain, some paresthesias, numbness in those areas. So etiology, either going to be a bone fracture, crush injury will do it. Here's your burns, can cause compartment syndrome. Overly tight bandaging. Anyone here athletic trainers beforehand? No? No one wants to admit it because you don't want to be called out? Okay. When you wrap, you have to do it certain ways in your hands, be certain positions so that you have flexibility. And if you do it too tight, then you can cause compartment syndrome because you can't have any expansion of the tissue. You can actually cause that by wrapping too tight. Compression of a limb during a period of unconsciousness. When we get to nervous system and neuro in the winter, we'll talk about different types of neuropathies, and one of them is called Saturday night palsy, when you pass out drunk and your arm's up in the air, whatever. You wake up the next morning and your arm is like numb and dead. Similar to that feeling where lack of blood supply causes the numbness and the tingling and whatnot. Surgery to blood vessels will do it. Blood clot can do it. Vigorous exercise can also cause compartment syndrome. Extension under pressure when muscle lengthens. So we always talk about working out as the up motion, which is the concentric coming towards you. But the really big way to build muscle is actually focusing on the bottom part, which is the eccentric coming down. The problem is if you do it with really, really heavy weight and you really control it, you can pop your muscle and cause a bunch of problems. But it's like running downhill is better than running up sometimes. You get better workout. Anyway, that will do it. Anabolic steroids, muscle growth too fast can cause compartment syndrome as well. Abdominal compartment syndrome, which is separate by itself, usually after a severe injury, surgery, or during some sort of critical illness. So abdominal compartment syndrome is very rare. There's got to be some sort of underlying cause that happened in. Usually it's going to be like a car accident, MVA, a crush injury. Remember, the wheel is right in front of her driving, so it's going to hit their abdominal cavity in the chest when it hits. So trauma, surgery, liver transplant, there's a ton of blood supply in the liver and you lose a lot, it can cause issues there. Sepsis, obviously, pelvic fracture, here's your eccentric abdominal exercises. And as the pressure in the abdominal compartment rises, circulation to and from the liver, bowels, kidney, and other organs may be restricted. So if blood supply to the kidneys is reduced, what's going to be the result? We'll find out next week, but acute kidney injuries, you can start seeing those issues, and so forth. So there's acute and there's a chronic form. The acute is the medical emergency, usually due by a severe underlying injury. Something caused it to happen and can lead to permanent damage. Chronic compartment syndrome, not a medical emergency, usually just by athletic exertion, exertional compartment syndrome. Okay. So complications, again, signs and symptoms of compartment syndrome, new persistent deep ache in the arm or leg. So here's another phrase, pain out of proportion. So you may look at a patient who's got compartment syndrome in the right leg, and you're looking at it and you're like, it's not really that swollen. It's a little bit swollen, but it's not that bad. But there's like, this pain is unbearable. That is pain out of proportion for what you're seeing on exam. You're looking at this like leg, and I don't see anything, but the guy's like, this is killing me, my leg. That is pain out of proportion to what you're seeing on exam. There are a few diagnoses that have this as well. This is one of them. Numbness, pins and needles, an electric type, that's from that neuropathy that's forming. Swelling, tightness, and bruising, especially with a cast or a bandage. So the treatment, obviously, number one, remove the obstruction if there is one. If you wrapped it too tight in ACE wrap, undo it. So whatever the obstruction is, the cast, remove it. You also see a compartment syndrome with like wedding rings on the finger when they get crushed and they pinch the finger starts getting swollen. Jimmy Fallon, that happened to him a few years ago. For a long time, he had like a big like a bandage all over his finger for a long time. So that happened to him. So the other treatment is if you can't remove anything, is what's called a fasciotomy, where you actually cut the fascia. And here are some nice pictures of what it looks like when you do a fasciotomy. You have to remove the pressure. So you cut that and it opens up. Now, something like this, when I was a student, I suggest all of you, if you work, when you do your ER rotation, do night shifts. You see, it's a different world. Different patients, whole different world. You'll do a lot more stuff at night anyway. Doctors don't care. You do a lot of fun stuff. Yes?
So you're just like cutting
Yeah, you just cut it.
and it just releases?
Yep. Now, this is spontaneous. That is done on purpose. Like, we actually took a scalpel and cut. So this burst. So this is what I was telling you. When I was a student, I saw a patient who had lower extremity lymphedema. So from her hips down, the legs were huge. They were taut, very swollen from lymphedema, but her upper body was like normal size, but her lower extremity was huge. So her legs were swollen all the time. She was sleeping at night, and her husband accidentally kicked her, and her legs split like all the way down. But something like this, but it just split. And you try to put it back together, you couldn't get it back together because of all the edema and the swelling. When you were trying to approximate the tissue back together, like just water was just oozing out from all the swelling going on. So this is spontaneous rupture. That is probably done methodically with a scalpel. You'll have to like put plastic over it, and then plastics comes in and they'll do the rest. Yeah.
What determines if it ruptures versus if like a person just dies from it?
Well, if they die from that, it's usually abdominal cavity. Compartment syndrome will make them
So
cough.
like the legs will usually like rupture before.
Well, no, you're only going to have it compartment in one area. You're not going to have compartment syndrome like both legs in your abdominal area. So wherever the compartment syndrome is, you just, if it's on the foot like this, you just make your incision, skin opens up, the fluid gets out.
But if you don't make the incision, it'll eventually rupture.
I mean, it can. If it gets swelling, it's so bad and more and more and more, eventually the integrity will lose. You don't want to get to that point. You want to get it here where you can just safely do it.
What do you do if it's spontaneous? Like, if it happens?
Oh, so, okay, when it's like that and you can't approximate the tissue, you get like Tegaderm, that plastic,
Okay.
and you cover the whole thing with the plastic, and then you wait for plastic surgery to come in, and they'll do the rest. That's where you consult out. Yes?
Wait, sorry, you said do night shifts.
You can tell them you want to do a few night shifts. You can't do it all night shift, but like when you make your schedule for ER, usually you'll be assigned to someone who has a schedule made, but you can request, hey, I'll kind of do a couple night shifts just to see what it's like. Alexa, you have a question? Alexa, you have a question? You, yeah. No? Okay. Anyone else? Okay. So that's a fasciotomy. Moving on now to osteonecrosis. This is disease of the bone. Okay, also known as avascular necrosis or aseptic necrosis. So just like I said with Paget's disease, also known as osteitis deformans, osteonecrosis, avascular necrosis, or aseptic necrosis. This refers to necrosis of the bone in the absence of infection. So the bone is dying off, and there's no infection, mainly there's no blood supply. And that's why it became necrotic. Temporary or permanent loss of blood supply to the bones. So you get, this is your avascular necrosis. A common site is the femoral head. You can see in this picture that the bone above this bone and this area right there, they look different. I kind of drew all over that, but there you go. You can see. But they look different. That is the avascular necrosis of the femoral head due to lack of blood supply. So etiology, trauma, emboli will do it. If you get a clot in that area, everything distal to the clot doesn't get any blood supply, so ischemia can form. Systemic diseases, here's our lupus. We learned about that already. That can cause avascular necrosis, radiation, focal bone necrosis. This is Legg-Calvé-Perthes disease. This is usually in kids, Legg-Calvé-Perthes. Thrombosis and idiopathic. So you can see here, we have ischemia down there, lack of blood supply, so lack of blood supply in the femoral head, and we get necrosis, no blood supply in this area, the tissue dies off. Obviously, the femoral head is a very, very important part of our movement standing up, And if this thing gets compromised and breaks, obviously you're not going to be able to walk as well. Very, very painful when you walk because of the necrotic tissue. So you can see here the way, here's the first little bit, and then it kind of spreads more of that head as it goes through. So it's called creeping substitution. Necrotic marrow is replaced by invading or creeping neovascular tissue and provides the needed pluripotent cells to make new stuff. We get necrotic bony trabeculae. We talked about the trabeculae before in Paget's disease. When that trabeculae gets damaged, the integrity of the bone becomes very weak as well. So this new woven, and you get collapse of the bone. Famous football player from 80s, early 90s. Career was ended short. He's probably the best two-sport athlete ever. Had this happen to him. Anyone know who that was? Bo Jackson. Played for Auburn, SEC guy. Was running, and he ran so hard and so fast that a player tried to tackle him, and they pulled his leg. And they held onto his leg. Well, his force of running forward was so strong that he actually pulled his hip socket out because the guy was holding onto his leg, and his force pulled it out. Well, when that happened and it popped back in, it tore some of these vessels in the femoral head. He developed avascular necrosis. He had to get a hip replacement. That ended football. Went back to baseball for a little bit, but that was pretty much the end of it. But all due to an injury in football, wound up with avascular necrosis. So what happens? We tried to remove all this necrotic bone and replace it with viable tissue. If it's small and not subject to weight bearing, the process may succeed. But if you're dealing with a weight-bearing bone, very, very rare chance that it's going to succeed. Unsuccessful in about 80% of patients, and usually the infarct gradually collapses and the bone breaks. At the end of the long bones, the overlying articular surface becomes flattened and irregular, so they get increased pain, and eventually they get osteoarthritis. Because we are dealing with the articular surface. It's going to ruin all those synovial joints, cause osteoarthritis type bone-on-bone movement in that joint. Most common is going to be pain for these patients. Small amount will have no pain at all. Groin pain is very common if femoral head disease. It's going to be complaining about groin pain if the femoral head is the problem, followed by thigh and buttock. Weight-bearing or motion-induced pain is the most common presenting symptom when they show up. Rest pain occurs in approximately 2/3 of patients, and night pain in about 1/3. Although rare, if you have multiple joints, there may be an underlying process going on. Usually, avascular necrosis will be just one area, but if it happens in different areas, something else is going on, you gotta start exploring different things. This is osteonecrosis of the gums due to bisphosphonates. Okay, so whenever you hear about bisphosphonates, and you'll learn about those later on, one of the complications is osteonecrosis, and this is what it looks like of the jaw. So when you guys do your mouth exam and you clip them with all the tongue depressors, you'll get a lot of pain in that area when you hit that, and you'll see it as well. Osteomyelitis now. So that was necrosis. This is an infection of the bone or the bone marrow, and that's what it will look like. It smells horribly. Okay, so when you get to the ER, you may see some of this as well. Okay, etiology. Obviously, a lot of bacteria that can cause these. Staph aureus. The Staphylococcus species. Yeah, Staph aureus is one of the big ones that's going to do it. One of the big skin bacteria. Difficult to treat due to bone anatomy. You have to get the antibiotics like really local, so it's very hard. So you can give like an interosseous injections right into the bone, but bone anatomy makes it very hard to treat these patients. So they get extensive physical disability. The other thing too is you don't know you have this infection of the bone until you get the skin complications. So by that time, it may be so far advanced that now that bone is now infecting the overlying skin that it's now creeping out for. So what happens? We get an infecting organism that makes its way into the bone and makes its way into the medullary cavity of the bone. When this happens, obviously because it's an infectious process, so we have to get all of our white blood cells here, so we get infected, pus-filled pockets of all those dead white blood cells trying to kill off all that area. When this happens, all this pus starts pushing its way out. And that's why on this 3, you get this whole big area here. That's all the infection. What we do is our body tries to form what's called a sequestrum. It's a way to, like we do with a GON complex, with TB, we try and isolate it and quarantine it. Same thing here, we're trying to sequester all this bacteria in this one little area of the bone. So we form this sequestrum, which covers the area to try and keep all that bacteria in that little area so it doesn't break out. There are 2 types of osteomyelitis. Exogenous, meaning the infection enters from the outside of the body. Open fractures, penetrating wounds, surgical procedures will cause this type of osteomyelitis. Here's your staph and strep, again, most common ones. Again, outside the body going in. Okay, when you do an injection or you do a blood draw, you have to read off all those what are the risks of getting a blood draw? You have to read all, if you inform consent. Well, why? If you don't clean the area off very well, you'll bring all those bacteria on the skin right into the bloodstream. So you have to clean off the area because one of the risks is that stuff. Endogenous, it's spread from elsewhere in the body. This is going to be common in infants and children, and the elderly, so extreme ages. Temporary bacteremia occurs and spreads. Site most commonly affected are the long bones when it comes to endogenous sources. So if you already have an infection in the body, so for example, if I said a lot of the population that got osteomyelitis are IV drug users, homeless people. Why? Because they're in environments where they're surrounded by a lot more bacteria than other people. If our IV drug users, are they using dirty needles? Those are all things that you're bringing in from outside sources in. So again, here is our infection. We have this necrotic cortical bone, which has been cut off from the supply because of all the infection. And we get this, remember I talked about those Haversian canals before? I said, remember that word? That's how the pus gets out. And what it does is it lifts the periosteum. You see how this periosteum here is lifted? Because the pus underneath it is pushing that periosteum out. So you'll see that on X-ray. It is abscess in the bone marrow, starts to spread through these little sinusoids, makes its way out to the cortical bone. Other sources of infection, this is osteomyelitis, obviously of like gum. Cutaneous issues, sinus, ear, dental infections are primary sources of spread. Soft tissue infections, GI, GU, respiratory infections can also get things in there as well. Total joint replacements can also cause osteomyelitis. You're putting a foreign body into an area. If it wasn't totally clean, stuff can happen. So there's some underlying causes of osteomyelitis. So what's going on? We get the inflammation process causing the abscess to form. Inflammation causes thrombosis and seals that caniculi off. That helps form, that's starting to form the sequestrum. All these inflammatory exudates, all that pus, extends into the metaphyses, the marrow cavity, and lifts the periosteum. When it lifts the periosteum, that causes necrosis and death of the bones in that area, producing that sequestrum, isolating it all out. Intense osteoblast activity response is called an involucrum. So the involucrum is new bone being formed in an area to replace the dead one. And we get these little openings in the involucrum, exudates to the infiltrate in the surrounding soft tissue. So this is how we get from the bone to the tissue around it to result in that picture I showed you at first where they have that macerated skin because it went from the bone through these little canals, these little sinusoids to the soft tissue, and eventually it worked its way up to the skin. So here's another way of looking at it. Again, here's all the pus formation. Here's lifting of the periosteum. Here is the trapped necrotic bone inside the sequestrum. And then the involucrum is that reactive bone trying to reform. What do you see on physical exams? Signs of inflammation, decreased range of motion in the area of the infection, drainage, sinus tract ulceration on the skin where the infection is. If the infection is in the leg, they're not going to have an issue in their upper body. It's all localized to that area. Complications, septicemia, bacterial arthritis if it gets stuck in the area, septic if that bacteria gets into the bloodstream and starts to affect other areas, pathologic fractures, so that bone is now weak. It can fracture totally because of the weak bone. Squamous cell carcinoma, and they have chronic osteomyelitis as well. Squamous cell carcinoma, obviously as that bacteria gets into the skin, can cause issues. Osteoporosis is there. Again, these are all disorders of the bone itself. Decreased bone mineralization, loss of bone mass, where the bones can't support the mechanical support anymore. So basically, enhanced bone resorption relative to bone formation. We're resorbing more bone that we're putting down, therefore our bones will get weaker and weaker. So hallmarks of osteoporosis: bone loss, bone fractures, common areas, vertebral compression fractures. Okay, the bones are weaker now, compressive forces, they collapse and they get smaller. Hips and Colles fractures. Colles fractures are the forearm. Why do they break their forearms? When they fall, they try and protect themselves. They have their outstretched hand and they break that too. That's a Colles fracture or a boxer's fracture. Underlying causes for osteoporosis: smoking, vitamin D deficiency, get out, get sunlight, low body mass. Being very light and frail doesn't help with your bones. Why? What law? Wolff's Law. The heavier you are, the more your bones are having to carry that weight around. They're going to have thicker bones. Hypogonadism. What are we missing with hypogonadism? Is that important for bones? Estrogen. Estrogen. So we have hypogonadism. Testosterone is important as well, but estrogen is more. Sedentary lifestyle. You're not moving, you're not stressing your bones, they're not going to get stronger. Glucocorticoid therapy, we talked about that with the cortisol. And alcoholism will also result in reduced bone mineral density. Usually osteoporosis, 5th or 6th decade, high incidence in whites and Asians. Hip fractures have the greatest morbidity, mortality, and direct medical cost. You could have a very healthy 75-year-old woman, out, active, goes to work, does everything she wants, has trips and falls, breaks her hip. They die 2 months later. It happens. It's rare, but it can happen. They deteriorate fast when elderly people get a hip fracture. What happens when you break your hip? Where are you going to be stuck now? In bed. And what happens if you're stuck in bed for too long? Now what are you at risk of? Clots and DVTs. Now you're immobile, so you can't move. So who's going to help take care of you? So the complications build up a lot just from one simple hip fracture. That's why we're so worried about elderly with strong bones and weight training and keeping everything okay so that they can support themselves. And they don't have all these problems. Mainly going to be in the neck or intratrochanteric regions of the femoral head is where it happens. So either here, between the trochanters, or the femoral neck. These are the main areas of fractures where they occur. They can occur, but it's usually pretty rare that happens. So bone resorption and bone formation occur continuously throughout life. After menopause, bone resorption is accelerated. Remember, estrogen suppresses osteoclast activity. Now you don't have the estrogen. So those osteoclasts now are unopposed. They start going a little bit crazier. And also with age. So we're going to learn that there are two types of osteoporosis. One is age-related, one is hormonal-related. The bone remodeling unit just refers to we have osteoclasts and osteoblasts. As long as their activity for both of them is equal, our bone will remain stable. Obviously, with age, less bone is replaced than what is removed, so your bones get more brittle. So either we get an oversupply, overactive osteoclast, or undersupply, underactive osteoblast. The result is lack of bone mass. Either we're not making it, or we're too fast in removing it. The concentration is going to go down. So these are the two types. Senile osteoporosis has reduced trabecular thickness. This is just, when you say senile, doesn't mean you're crazy. It means you're old. Okay? In medical terms, senile just means old. So senile osteoporosis is age-related osteoporosis just from being old. Postmenopausal osteoporosis shows disrupted connections between the trabeculae. And we'll go through more detail in a minute. The end result is the same. They have osteoporosis. Obviously, if it's due to estrogen loss in a woman, you just replace the estrogen and it brings it back. If it's senile osteoporosis, what do you think your best bet for that person is? Weight-bearing exercise. Okay. Medicare right now offers a free program called Silver Sneakers, where they work out, they do all this stuff. Also, if you're trying to tell your patients how to get more exercise in, park farther away at like Publix. Don't worry about that closest spot. Park farther away and walk in. Or go to the mall before it opens. All the malls open up before like the official open. It's air conditioned, it's cool inside. They can do laps and they can walk in the mall before it opens. A lot of people do that as well. There's ways to sneak in exercise for your patients. Don't let them fool you. So, primary osteoporosis, mainly postmenopausal women are type 1, and type 2 is your senile or age-related osteoporosis. So type 1 is estrogen problem. Type 2 is age-related. So type 1, absolute increase in osteoclast activity. Why? Again, estrogen dropped, not suppressing osteoclasts anymore, so they can go crazy and they degrade your bone. So estrogen withdrawal directly causes an increase in osteoclast due to the reduction in the cytokines. Type 2, age-related senile osteoporosis, generally after age 70, so they have to be very old to do that. Results reflects decreased osteoblast function. So type 1 is increased osteoclast, breaking them down faster. Type 2 is reduced osteoblast activity, so we're not building it back as fast, so we're still losing it. Secondary causes of osteoporosis. This is usually due to an underlying endocrine or genetic problem. Iatrogenic, here's your corticosteroid use. This is a secondary cause. They don't have osteoporosis because of estrogen problems or age. Their osteoporosis is due to the medicine that I'm giving them. So it's a secondary osteoporosis due to rheumatoid arthritis, as an example. Corticosteroids inhibit osteoblast activity, impair vitamin D, so we know that, therefore, it's going to have a problem with calcium. Hyperparathyroidism, so we're constantly making PTH. Hyperthyroidism, hypogonadism, malignancies, malabsorption, and alcoholism. So these are some causes for secondary osteoporosis. So if someone comes in at 50, they have a fracture, you do a bone mineral density, it's showing low. You know it's not senile because she's only 50. Doing your medical history, if you ask for her last known menstrual period, and she said it was a week ago, you know she's not menopausal. So there's got to be some underlying cause for this osteoporosis. Start digging. Do they have any? Are they alcoholic? You know, how's their diet? Then you start checking your labs. You do your PTH, all those things. But you got to figure out the bottom. Etiology, genetics, peak bone mass is increased in men and African Americans, so check for family history. What's their calcium intake like? And it doesn't mean just drink more milk. You know, what's calcium like? How's their absorption of calcium? Any environmental factors? Do they smoke? Exercise is obviously important. Are they sedentary? Things to watch out for. So again, here's your different cheat sheet for review for osteoporosis, the fractures in the hip, the wrist, your vertebral fractures, and the causes for osteoporosis. Postmenopausal osteoporosis is usually 10 years postmenopausal. So yeah, she's 50, but she hasn't gone through menopause. Even then, it takes like 10 years before you start getting significant bone loss where it'll show up on the scan. What else is there? Again, senile is after 70. Signs and symptoms, usually going to be asymptomatic. Osteoporosis doesn't really cause pain unless you get to the point where you have a fracture. Then you'll get pain. So you get these vertebral compression fractures. Kyphosis you may start getting, called a Dowger's hump. They start leaning over. They can't stand up. Loss of height. So you see how these elderly women, they start shrinking. Next time you hug your grandmas, now you understand why they're shrinking.
I thought you said ugly too. I thought you said you see these little ugly ones.
Oh, no. Oh, no. No. Yeah. No. Elderly or ugly. Yeah, we're done. So here's another mnemonic. Access for osteoporosis. What are the risk factors for osteoporosis? Way to remember that. And we're done with musculoskeletal. Okay, see, have a great weekend. Good luck on farm.